We're done with the hands. Now on to...
They're okay. They landed on the couch.
You already broke them, so
I already broke them anyway. So, Tyreek Hill. Oh, did you see that?
I saw that and I felt
ouch.
bad for Tyreek Hill.
What happened? All right, Charles, your turn. All right. So basically, it wasn't his right leg. However, what happened? So basically, he's going down and the player grabs his right leg. Yeah. Okay, but you're gonna see right on this video. So let's pretend this is his opposite leg.
Right.
So the guy's grabbing his other leg.
Right.
He lands, and you can see how this suddenly just twists.
Yeah.
And it just turns the other way. And then when he turns around, it's pointed the other way. Like it's a hinge joint on this particular one, so I can't twist it. But it was pointing in the opposite direction. And there were some people that thought, oh my God, it's his ankle.
Yeah.
But it wasn't.
It wasn't as the knee dislocation.
It's a knee dislocation, people. So knee dislocations. And Dr. Rosie Sander is a hand surgeon, but also a fully fledged fellowship trained trauma surgeon. And what is the most important thing that we have to deal with when you have someone suspected of a knee dislocation?
Well, you have to check the pulses.
Pulses.
Right, because that's the biggest thing that we worry about. That
exactly.
That popliteal artery.
So if you dislocate, this is what he did, right? So he lands and he basically twists. And it's basically dislocated and twisted out like that. He basically went like, now I don't know if it was anterior or posterior. I can only go based on the supposition of what we saw on the video. But in order for your foot to be turned a certain way, we can make the assumption. And what happens? What's right behind here? The tibial nerve, sciatic nerve, tibial nerve, popliteal artery. And when that gets disrupted, you lose your pulses. And what can happen? You can lose your leg.
Lose your leg. It's one of the most serious injuries that you can sustain.
And you can probably count on your hands how many times, we would see it in training. It's not that common, but when it happens,
it's you have to be on it right away.
Right away.
So I think I've seen 2 maybe pure dislocations and I've spent a lot of time in trauma.
Right.
And I've only seen 2.
Right.
So he's already out of surgery.
He's out of surgery.
He tore ACL multiple. It just says
it's multi-ligament for sure.
But he's already out of surgery.
Already out of surgery.
Well,
yeah.
if you're going to dislocate, it's multiple ligaments have to get injured for a true dislocation.
Yeah. So, okay.
That's his knee.
So yeah, I don't want to make fun of it, but I just want people to realize that in order to have a multi-ligament injury, your knee is this floppy, and it hurts like.
Yeah.
I don't want to say it, but we'll just say gangbusters.
Yeah, it hurts.
But it hurts, right? And so what do we have to do? So first things first, it's like the ABCs of CPR, airway, breathing, circulation. In this case, what's the air to the tissues? From the blood vessel, right?
Exactly.
So what do you have to do?
So you have to put the joint back in its normal position so that you can restore the blood supply.
So you get it like this and you do external fixation.
Right.
That's the most common thing. Acutely, just to stabilize the leg, you reduce it. You whatever drugs you need to basically put that patient out. Or if you don't have that opportunity and he's sitting on the field, he's at risk for ischemia. And then secondary. So we're going to get into that. But you can get a compartment syndrome from revascularization from flow, or if it's truly ischemic, you can get that. So you have to stabilize the leg. And then you've got to check his blood supply again.
Exactly.
And what is the most important thing when you have an injury like that, when you call and say, I need an external fixator, I have a knee dislocation, and I also want
I want a
vascular surgeon in the room, and you need a CT angiogram.
A CT angiogram.
Or if you don't have time, Sometimes you don't have time. I mean, for true trauma, like trauma that's like multi-vehicular, where you get lacerations, or someone is actually traumatic in the point where they're losing the limb, you may have to do it in the OR,
exactly,
on table
but that's
angiogram.
why you have everybody you need in the OR.
Right.
You have every possible tool at your disposal, because you have to game out what could be injured. And so, and again, like you said, sometimes we don't have the luxury of time to do all the investigation. So so you just have all the right personnel, all the right tools ready to go.
And sometimes as orthopedic surgeons, when it comes to emergencies, this is a true emergency that we bump almost everyone, except for someone with a cardiac issue. But usually you have multiple rooms. You're going to a high-level facility where they can open up an additional room, call in a special team, and everyone's there. And so everyone's there. He's already out of surgery, which makes sense. This happened last night. Boom. It happens. So now, at the time of his injury, multi-ligament, what do you think they did right away acutely? Obviously, we know that they want to stabilize it, keep it, stabilize, external fixator so it doesn't move. Because why is it that you have to use the external fixator?
Well, you don't have the ligament support. Right.
Yeah, exactly.
Right, so
and then they have to work on the vessels. And if the vessels don't revascularize on their own, you have to get the vascular surgeon in. They have to assess the vessels, say they have to do something, right?
They might have to do a repair. They might have to do
a graft.
Anything.
Yeah, so we don't know exactly what happened during the surgery, but external fixation, maybe definitely revascularization, but whether a graft or surgical intervention or a bypass was required for the vessel injury, intimal tear, major vessel injury, disruption, we don't know. Usually though, for this type of trauma, non-penetrating, typically, if it's going to be a vessel disruption, it's not like it's cut.
No, more like a shearing type.
Intimal shearing tear, where the vessel actually has issues around it, but it's intact. But if you don't get to it on time, it can clot.
It can clot, exactly.
And then you run into more problems. So, and we've all felt like, say we put our arm over the back of a chair, and then it goes numb, or you're just sitting for a long period of time. You wake up and you got tingling going over. Well, with blood vessels, right? Same thing. Blood flow stops. All of a sudden, the body says, whoosh, send the blood flow there, so you get this swelling
that occurs, and
which results in that
risk of compartment syndrome.
So compartment syndrome can happen. And so sometimes with these, we have to do a prophylactic compartment syndrome.
Exactly.
So that's the other thing. It's scary when this happens for the patient, because, we have the experience, we know what we're doing. I don't do trauma anymore, but, you just go in there and you do what needs to be done, which means that sometimes you may have to, if it's more than a certain number of hours, you do the incisions for preventing prophylactically a compartment syndrome from happening.
You need to release the pressure, essentially, so that we don't have a loss of limb later on.
Right.
Loss of the muscle, loss of neurovascular structures, and
the nerve. So the nerve could be injured as well. So we don't know. More than likely you can have some type of a neurotmesis, axonomesis, some type of a neural injury. And what that means is either the fibers inside rip apart and the sheath is intact, or there's a complete disruption of the nerve as well. In this case, usually it's a stretching of the nerve, so typically we expect it to come back, but it's variable.
It's variable. For example, like the perineal nerve.
Yeah.
When it gets injured, the recovery is the recovery can be very slow and sometimes incomplete. Right. So, and that's one that's prone to not having a complete recovery.
Right. And the perineal injury comes from the outside the perineal nerve. You can often get a foot drop or weakness in the extensors of the toes, and that can be a big problem. And so, again, this is educational about the injury. We don't know exactly what happened, what is injuries. We don't have all the details about what happened, but we are talking about scenario of a knee dislocation where you could be at risk for nerve, vessel, and definitely, there's no question he's got multi-ligaments. And just by a knee dislocation itself,
You have
have to tear multiple ligaments. And so, ACL is likely, could be the PCL,
Right.
could be MCL. Posterolateral corner, based on what I saw on that, I really worry about his posterolateral corner as well, but you can have a complete ligament injury. And so then there's different theories about what you do in a situation where, I know you're more trauma, I'm more sports.
Right.
And so it's kind of like, all right, the trauma, we've taken care of, the leg is stabilized, you do the sports, right?
Exactly.
But even then, it's variable. Do you do the ligament reconstruction right then and there? That's a lot of surgery. Just to stabilize the leg, whether or not he has nerve and vessel, and then to do the bone tunnels for the reconstruction, repair of all of the ligaments. More than likely, he had the initial stabilization to prevent any neurovascular injury, and then you have either a subacute, meaning a few days to a few weeks, or a delayed reconstruction where it could be longer than that. Now, in today's day and age, you can get really good hinge fixators. So you could actually stabilize the leg, and then you can do the reconstruction once the swelling comes down. His risk of compartment syndrome is down. He has a warm leg that has sensation and function. He can move his toes. He can raise his foot up and down. You know his neurovascular status, and then you can say, all right, we know his status, now we can do the reconstruction.
Exactly. Yeah, and that's always been my experience, that usually the ligamentous reconstructions or repairs are done on a delayed basis, right? We just make sure that we stabilize the limb. That's the first thing, just stabilize the limb, let the swelling go down, and then come in to do the final reconstruction repair.
Exactly. Because, if he needed a graft or some vascular work in the back, the last thing you want to do is be drilling bone tunnels in there. He may need to have further surgery. We don't know that. But again, major injury, but luckily we have the technique, the technology, and the tools, and the understanding to do what's needed for this type of injury. So, wishing you well.
Exactly. Wishing you well, Tyreek.